For example, for the metastatic pancreatic cancer, we tried to, as you know, there are not many treatment options which we can offer to our patients who are suffering from metastatic pancreatic ductal adenocarcinoma. So after the failure of standard treatment options, we created a molecular portrait, a molecular profile of our patients, and tried to figure out whether we can offer them a molecular-based treatment or not. And the problem is, so that's the main challenge we are facing right now, is the long turnaround time. Because from the time we decide to create or to profile the molecular landscape of the patients till we can start their targeted therapy, it takes about 2 months. And that's plenty of time. That is the problem. And in this time period, in this time interval, many of the patients deteriorates regarding their health conditions. So they are getting worse and worse. And particularly in cases of pancreatic ductal adenocarcinoma and colorectal cancer, the liver metastasis can progress, and this leads to increased bilirubin values in the blood serum. So the increasing bilirubin means that we cannot apply the targeted therapy anymore because the liver function is impaired, severely impaired. So that's the problem. So we are thinking about how we can overcome these problems, how we can tackle these challenges. So I think the best way to start the targeted therapy at an earlier time point is to create the molecular profile prior to the failure of the last standard therapy line. So, for example, if I have gotten a patient who was treated with gemcitabine and nab-paclitaxel in the first line, and in the second line was treated, for example, with nanoliposomal irinotecan and fluorouracil, I have to consider that prior to the failure of nanoliposomal irinotecan combined with fluorouracil, I have to think about a molecular profile because I cannot afford to wait approximately for 2 months to start the targeted therapy, because in many cases we are then too late. So that's the problem. In 50 patients with metastatic pancreatic ductal adenocarcinoma, we had recommendation rate above modest, I know, but in other diseases, for example, biliary tract cancer, we had a recommendation rate about 60%, or colorectal cancer, we had a recommendation rate about 50%. So even 20%, above 20% in metastatic pancreatic ductal adenocarcinoma is, I think, for this disease entity, which is quite aggressive and bears a dismal prognosis, quite acceptable for now. But we have to think about time as a critical factor, as a highly critical factor when we are trying to offer the patients precision medicine approaches.